define vaccine hesitancy. Vaccine hesitancy really is when you ask somebody a question, are you going to get the COVID-19 vaccine or any vaccine? When it's available, people say, well, I'm not sure, maybe no. And the reason that people say no is really variable. It depends on the context. It depends on the time that the pandemic has been around. It depends on what they've lived through in terms of the health and well-being in their community. And it's also dependent on barriers. Is it easy to get? Is it convenient? Or do they have confidence in the vaccine? So let's look at some data to see why is it so important for communities of color to really understand the value of getting a vaccine. The CDC reports the data, and you can see from here that compared to whites, American Indian, Black or African American, or Hispanic or Latinos suffer many more cases of COVID vaccine. But if you look at hospitalizations and deaths, the proportion is significantly higher. And because of these higher proportions, it's really important to get vaccines into arms of these communities because the vaccines have been proven to decrease severe illness that results in hospitalizations and decreases deaths. And we need to understand the no and the unsure. Overall, the rate is about 31%, but if you break it down into different groups, still for the African American Black population, about 22% say they're no or unsure. For the Hispanics, it's 21%. And interestingly, for the white population, it's about 34%. So still a significant proportion that we need to get vaccinated to get out of this pandemic. So what are the questions that people are asking, and why are they not getting the vaccine? It really centers around understanding the safety of the vaccine. Is it safe? Does it work? And were people like me represented in the study groups as the drug manufacturers were developing the vaccine? And these are the main questions being asked. Because once people understand that, those that are unsure or no may move to maybe or yes. And you can see for adoption, it's a wait and see attitude. And recent data really shows that the populations in the Black, African American, and Hispanic, they're getting their questions answered, and they're really moving forward to getting vaccinated. So what are the factors and barriers that are driving this trust or lack of trust and the ability to adopt vaccinations? They're factors like language barriers. Do I understand what people are saying to me in English? And even if I understand English, do I have health literacy to understand what some of these statistics mean? If I see a practitioner, do they understand my cultural beliefs and practices? Do they have a bias against my racial and ethnic group? And can I get to these sites where vaccines are being provided, or are they inaccessible to me? Are they providing vaccines in the areas where there's a greatest need or not? And these are the factors that define social determinants of health. They are factors that really are important in driving general health and well-being. And when these social determinants are creating barriers, that's what drives health disparities. And health disparities are preventable and unfair differences in health status between segments of the population. And the key word is preventable and unfair. If we address the preventable issues by addressing the barriers driven by social determinants of health, we can achieve health equity, which is where every individual can achieve their full health and wellness. Now, where do individuals seek information about health, the questions that they have to trust information? And it's really interesting. When you look at this, the African American and Hispanic and Latino, they trust the science. They trust their doctors and nurses, local public health officials, and the CDC, as well as pharmacists, families and friends. Again, that's the community, that's the social determinant of health. And religious leaders are trusted as well for information if they're partnering with the science-based experts. And what are the questions where we get asked the questions of why should I trust this? It's really around what we've touched on already. What are the side effects and what is the effectiveness? So Cigna has looked at this data and really has created a commitment for health equity. And part of Cigna's work is to understand what does the community that suffers from health disparities need to know to gain trust in the system. So let's take a look at Cigna's commitment to health equity. Our response has really been to support our clients and our customers and the broader community with the information they need to accelerate vaccine adoption once the supply meets the demand. It's also delivering targeted resources to the communities that need them and really providing information as to where vaccine is available. And we're also advocating at public policy levels and communities and at the employer level to support vaccine distribution and access. And this really is something that it takes a village, right? Cigna, it's important, but we know that we need to collaborate with others. So it's really my honor and privilege to bring in the rest of the village, and that is today's panel. So let me introduce Mrs. Anita Jenkins, who is the Chief Executive Officer of Howard University Hospital. Good morning, Mrs. Jenkins.
Good morning.
And good morning. And Dr. Yele Aluko, who is the Chief Medical Officer of EY Americas. Good morning, Dr. Aluko.
Good morning. Thank you for the invitation.
Thank you. So we've talked a little about health equity, health disparities. We've talked a little about the social determinants of health. Dr. Aluko, I'm going to start with you. We know there's some issues about implementing the vaccine, but can you talk a little bit about the vaccines, the three of them, and what we know about the safety and efficacy, particularly in groups that are typically subject to health disparities?
Yes, I'm happy to do so. So as we well know, there are three vaccines that have been approved under emergency use authorization in the United States by the FDA. The Moderna and Pfizer vaccines came out first, approved sometime in December, and more recently, the Johnson & Johnson vaccine. Now, the first two vaccines, the Moderna and the Pfizer vaccines, are what we call messenger RNA vaccines, which is new technology being used to rapidly develop vaccines at scale. The Johnson & Johnson vaccine is a type of vaccine that has historically been used in the human population. The Johnson & Johnson vaccine is an attenuated adenovirus vaccine. In other words, the J&J vaccine uses a viral vector. In other words, it is designed to carry a piece of the dead virus, which is injected into the human body. And that elicits an immune response because the body recognizes the presence of a foreign object, which is an attenuated, partially damaged, deactivated adenovirus. Adenovirus causes the common cold. Now, the messenger RNA technology is completely different in that there is no viral vector. There is no virus injected. Synthetic messenger RNA is injected, and we need to understand the relationship between the DNA of a cell and the messenger RNA. So very quickly, let me just do that for you. Every single cell has within its nucleus a DNA, which is a double-stranded helix, like a spiral staircase. And that stores the genetic footprint of every single cell and every single human being. The footprint is the same. If the body needs to make cells, muscle cells, or any other type of cells, the DNA instructs a messenger RNA, gives it the message and says, go to this distant location in the kidney and make more kidney cells. The messenger RNA takes instructions from the DNA, goes to a remote location and replicates, maintaining that fundamental genetic footprint of that person. So what's happened here is that synthetic messenger RNA has been developed. And that synthetic messenger RNA has instructions synthetically developed that tell cells to recreate the spike protein that the coronavirus has. Part of the spike protein. Once that happens, the body recognizes there's a foreign element within it, and it now develops antibodies. And it begins an immune response. So in essence, the body's primed to develop antibodies, immune response, without being inoculated with any living or partially killed virus. So that's the difference.
Great, thank you. So, Mrs. Jenkins, you are the Chief Executive Officer of a large hospital. Dr. Aluko just described the different vaccines. How have your staff been communicating the safety and efficacy of these viruses, not only to your own employees, but the community in general?
We battled the coronavirus all last year. And as a matter of fact, my start date was February 17th, 2020. And in going through working with this illness, I knew that my staff and team saw people, and then they saw here in Washington, D.C., this disproportionate amount of people who were sick with it, critically ill with it, and dying from it. So we started seeing those numbers and those changes quite early. So when there was talk of approval, approval of a vaccine, I was very excited. And we started having conversations. I started with my leadership team on this very, Zoom screen. And in the chat room, my leaders, 140 leaders, directors, nurse managers, physical therapists, those kinds of things, and C-suite people, they started putting in the chat room, can I trust it? What about Tuskegee? I don't want to be experimented on. And I knew right then that we internally had to educate our team more and more and more. The complexities of how a synthetic virus is created, even among healthcare providers. You have to tell that story over and over again and answer it differently, because while we were educating and while Dr. Aluko is telling how the science works, there was also another messenger, right? To use the language of coronavirus. This messenger was public opinion, social media, and politics. Our team was just inundated, if you remember, with all kinds of information. I won't say what kind of information, but there was lots of kinds of information. So immediately we started having daily informations on how the virus works, coronavirus, but mostly about the vaccine, what it's doing, who was part of it. And I was very careful to say, especially in one of the studies, 10% of the participants were Black. And so, it's like, wait a minute, you are a part of this study, which African Americans historically have been left out of studies, or we have medicines where females aren't in a study, that happened in cardiac studies, right? And so it was so important to tell them the truth. We did a study among our team. It was small, but significant enough to be accurate, where 70% of my staff initially was not going to take the virus. And as we started putting out these daily briefings, these updates, it was only 2 or 3 questions per day and the answers. I put on there, if you have any additional questions, I will answer these questions for you. So of course, with the help of the scientists at Howard University hospitals and my expert physicians like Dr. Aluko, I had the answers. I'm not the doctor, but I've got lots of. So we started answering these questions, and so they started out with, wait a minute, it's going to change your DNA. Wait a minute, I heard it was this. Wait a minute, I heard it was an experiment on Black people. And then the questions started getting far more reasonable. I'm pregnant, can I take it? I have an illness, should I take it? So there were legitimate questions, and then we had to stamp out this narrative that somehow Black and brown people were more at risk from the medical community. They're doing experiments on us again. They don't care about us. And as radical as this will be how they will wipe us out. I heard that kind of language. So it was very important to just really start having this narrative. And then I started getting, hey, if you take it, I'll take it. That is why I was first at Howard University Hospital and Howard University to put my arm out there. Was I nervous? Absolutely. Was I confident? Absolutely. That this was the right thing to do. And it greatly increased our numbers. We have had about 60% of our staff, who is a great deal of Black and brown people at Howard University Hospital, have taken the vaccine. And it's in pockets, and they are slowly still, to your data, they are slowly but surely stepping up. They're hesitant, and now they see more information. I put out videos to the staff. It's day 24. I'm still good. It's 2 months now. I'm good. You just needed to build that confidence. There is so much mistrust because Black and brown people historically have not been treated well. Even how are they treated? Do they get respectful care? Do they get the same narratives? There is still language out there that Black people don't feel pain like white people. And when Black people know that, they're going to mistrust. And so I am still meeting with churches. I am still having meetings I had a Wednesday night prayer meeting 2 weeks ago with well over 100 people on the call so that we could talk about this virus with their pastors, 40 pastors. And so that we could do that. So that's how.
Yeah, awesome. So Mrs. Jenkins, you've referenced a lot of the literature and the cultural background that those of us who work in health equity are really aware of. This isn't new news for those who work on this. Dr. Aluko, what's new about this pandemic that it's really giving us the platform to shine a light on health disparities and take advantage of this spotlight to implement changes? Can you address that?
Well, let me first of all say that you give a very good oversight on health equity and the social determinants of health. The concept of health equity is an aspirational one. And I say that because societal equity in of itself does not exist in any country. So we have to first of all agree that we are on a journey, and the North Star is the intent to achieve health equity in the broader context of societal equity. The focus should be on health disparities. It is because of these health disparities that there is not health equity. When you say what is new, I will tell you that nothing is new, yes, except for the fact that it's the stark reality in 2020 and 2021 that such drastic disparities could exist, being played out in real time throughout all media outlets every single day, was shocking. But for those of us that have been students of health disparities and racism in medicine for more than 2 decades, this is not new. There is a painful history of systemic drivers that create vulnerability for disease risk, that result in delayed diagnoses, that are compounded by access to healthcare difficulties, that are also accentuated by sometimes disparate care within the bricks and mortars of health systems. So it's not new. And when we talk about vaccine hesitancy, while it's an important topic, what is really, the topic really is that there are health disparities It is the disparities that we've known about for centuries in organized medicine in the United States, that we've failed to move the needle on that. The publication, reams of literature, roadmaps, white papers that have been written, a roadmap to achieving health equity, dating 25 years. This is not new, but there is a broader societal awareness about the moral injustice. And there's a louder clarion call by broader society, corporate America, community, business, that this cannot continue. So what is new is the groundswell of support that this doesn't make any sense. We can do better in the United States of America.
Yeah, it's really true. And there's an officer of health equity now at a national level of leadership from the White House. So it has been recognized. So as we look at the distrust data, we've actually seen that a lot of the efforts Mrs. Jenkins, Dr. Aluko, Cigna, all of us have done really has decreased the level of vaccine hesitancy. And there's a light at the end of the tunnel. As vaccine becomes more available, we need to ensure that people are lined up to get it once supply meets demand. So Mrs. Jenkins, as we emerge from the pandemic, what is your healthcare system getting ready for, not only in terms of returning to more freer type of movement, but the concerns about delayed healthcare? What is your staff doing about delayed or avoided healthcare that happened during this pandemic?
So to Dr. Aluko's point, we've got some social inequities that make it more difficult to have good healthcare among some of these, some of the groups of persons that we talk about, whether it's real food access or access in travel to physicians' practices, where can they get regular care, all of those things. What hospitals and what healthcare, especially in the United States, became was sick care, right? All we do is take care of the sick, and we don't promote health. It is important for me personally, and at Howard University Hospital, with the history that this organization has, and this institution has. Well, it was born to, it was started to take care of formerly enslaved persons. We're no longer formerly enslaved persons, but the discrepancy in how people can get and achieve healthcare, or what's their knowledge about how to take care of themselves. The reason why we saw so much death and dying with the coronavirus was because we've got this big upswing of hypertensive persons or a heart disease or diabetes. Why do we have that? Because the food access or freely exercise. They build new beautiful communities and every single one of them have sidewalks. Well, if you're in a community where, first of all, there's too many people in your home, the richer you are, the more space you have per person, right? And so when you have that, it's easier to be well, to rest well, to have quiet, to have peace. If you have all of these people, we had a family, a Hispanic family that came into Howard University, the whole family got sick. And then we realized they're under the same roof. And so when you have those kinds of disparities that make it harder and harder to be well and stay well, we are now going back to the beginning. I'm participating, I love to cook. And I'm participating in some of the leaders in Washington, D.C. We're going to cook, and we're going to cook good food, cheap food, how to make bean soup and collard greens without a lot of fat, salt, all of those kinds of stuff. Make it taste good. And we're going to do that on TV. I'm a little nervous about being a TV cook, food network person. But we're going to do that because we've got to go back to the basics to help our community. And then we're going to encourage them, please go to your doctor. You talked about hesitancy. We are still trying to convince people that we figured out how to be safe, pretty safe in a hospital. Please come in, you've got a hernia. Please come in, you haven't had your blood pressure medicine in 6 months. Please come in, you know you have heart disease and you're still eating the same. So we've got to make friends with the community we serve and then move forward with at a better rate of being a part of that community so that they trust and they have tools to take care of themselves better. Not sure if I answered your question. Such a great question.
Yeah, thank you. So part of what we think about in terms of health disparities, social determinants of health, has driven really higher levels of chronic conditions in marginalized communities, cancer, diabetes, stroke, heart disease, higher risk. These may be overwhelming the system, and gaining that trust and having people come in, as you say, is really key. So Dr. Aluko, in the literature, there's a lot of information that says when you see a doctor that looks like you and understands your culture and lives your culture, you have better health outcomes, right? Yet, there are only 3% of the physicians are African American or Black versus 13% of the population being African American or Black. What efforts should we be putting in place to successfully increase the number of diverse representation in the healthcare system generally? Howard is a beacon, right? But everywhere else, what do we do to encourage more students of color to go into medicine and STEM fields?
I'll answer that question in two lenses. The first lens is that there's about 3 to 5% of physicians in the United States are African American. The population is 13%. It's a big gap there. But we need to understand that if there were 13% African American physicians in the United States, that would take a long time to achieve. There are not enough Black physicians to take care of Black people. There are not enough brown physicians or Latinx physicians to take care of that demographic. So seeking to accelerate that number is good. But what is also important is to ensure that all physicians are trained within the context of cultural competency. It is not unusual for a person to seek some commonality with people they do business with, and people that take care of them. But if people are skilled fundamentally in their trade, but have taken the steps to understand certain nuances, then you may actually find that on occasion, and this is a fact, that a Caucasian physician is culturally adept to take very good care of an African-American physician. The focus should be on cultural sensitivity, and vice versa for African-American physicians to be culturally sensitive to the portfolio of demographics they will see. Mm-hmm. You're speaking about pipeline development for medical education for minority physicians. The percentages have actually gone down. About 15 years ago, it was 5%. Now it's about 3.5%. The historically Black colleges and universities have traditionally been the institutions that have trained minority physicians, the Howards, Meharys, the Morehouses, and so on. There is a legacy of racism in medicine, in that the refusal to open up opportunities for minority physicians is a historical fact. Mm-hmm. Those conversations need to be had at the highest level of institutions that Mrs. Jenkins belongs to, the Association of American Medical Colleges, and they have begun to happen. Strategies should be put down with goals and roadmaps and target execution timeframes by which leaders are now held accountable. There need to be inroads made into educational institutions to foster pre-med access. But to expect it to happen just because there is this notation of this gap disparity, which again is not new. What is new, but what isn't said, is that that gap is getting worse. There needs to be a deliberate strategy at the highest level of governance. Many years ago, I used to be on the board of the Association of Black Cardiologists. And we did a landscape analysis of all the residency training and fellowship training programs to understand which programs had trained Black cardiologists. And we were shocked. We were not surprised, but shocked to realize that for up to 50, 75 years, there were several institutions, highly branded institutions, that had not ever trained a African-American cardiologist. And that's the specialty level, not the primary care level. So there's a lot of work to be done, but it's going to take real, deliberate, responsible, strategic thinking leaders that are willing to embrace the reality of the history, acknowledge that it is wrong, and let's do the right thing.
So, thank you. Thank you for that. The questions that I have, so we've talked about health disparities, health equity, social determinants of health, trust. I'm going to ask a question of both of you. Mrs. Jenkins, you as an employer, and Dr. Aluko, you as a chief medical officer. When employers put together their benefit plans and their structures, why should they care about health disparities? Should they be considering it, right? So Mrs. Jenkins, I'll ask you to start as an employer. Why do you think about health disparities, and why is it important to you? And Dr. Aluko, I'll ask you to follow Mrs. Jenkins.
I absolutely do. First of all, from a moral standpoint and as an employer, I have the opportunity to help people's lives get better. So not only do I want to create an environment in the workplace where they love to come to work, they have the tools and education that they need to do the best job for our patients, caregivers. Boom. But what I also want to do, it is good business to have healthy employees who have access to mental health care, who have access, easy access to their health care plan, and that they understand that it is of a benefit to them not to be sick. Down to, do we have an opportunity to give someone stop smoking classes? Do we want them to live and not get cancer? Yes. Do I want them not to be off because smokers are sick more? Yes. So not only is it the right thing to do, it's good business to understand that a good healthcare plan that promotes wellness, and I know that's a buzz phrase right now, but there are so many people, especially Black and brown, that eye roll you if you say wellness. Well, that's for people who get a chance to take yoga class. And they are not understanding that wellness is because they don't have a wellness plan for their lives. They can't get their hypertension into check, right? Are they getting the medicine and the healthcare that they need? Or do they understand that they cannot eat fast food 3 or 4 times a week and expect to maintain their health with diabetes and hypertension? So it is those kinds of things that I absolutely feel a responsibility that a strong healthcare plan is good for our staff, it's good for business.
Thank you.
Thank you for that insight. I totally agree with you. COVID-19 has shown all businesses that yes, they are indeed directly or indirectly in the business of healthcare. Talk about a food manufacturing plant yes, that depends on the large workforce of brown and Black people, sometimes migrant workers, ground to a halt within a matter of weeks because of a pandemic and because of the ravaging infection that was spreading through their human capital portfolio. So the realization that workforce resiliency can be deliberately managed through for an employer having a better understanding of the health of the workforce is critical. One of the things that COVID-19 has also done in big businesses, in Fortune 500 companies and so on, is that there's now a realization that employees at work sitting shoulder to shoulder with co-employees, working elbow to elbow, all of a sudden they're realizing that they are unbeknownst to them, working with people that are at significant risk for infection from COVID based on, unbeknownst to them, living conditions out of the office and significant risk of death. With that insight, questions that we are now being asked within our client base is, what is the world doing around developing a better understanding as to the health of their workforce? We provide health resources, provide health coverage, but should we be doing more to understand if our employees are actually using these resources? Should we be doing more to understand those that might be at risk, not just for COVID-19, but at risk for other types of chronic disease? In other words, adopting a strategic, forward-thinking approach to enhancing workforce resiliency. Many programs, many employers have excellent resources that are provided to their employees, but most of these are complicated to navigate on web pages, and businesses are now thinking, should we begin to put push notifications, incentivize, identify healthy habits, provide access to healthy lifestyles and behavioral choices, and make that part of the DNA of the business?
So we're talking about health disparities, and Dr. Aluko totally aligned with you on wellness and initiatives and push communications. If we're talking about health disparities in specific populations, is there a great example maybe where you've seen of addressing maybe with a different benefit or a different approach or a different communication, targeting a population that may have special needs within the context of a broader benefit package? Could you share if you've seen any examples like that?
So what I'm seeing is businesses now beginning to develop this. And I want to emphasize that this issue of disparities goes beyond race. So if we look at just race, we are ignoring other aspects of vulnerable populations. Therefore, what we advise businesses to do is, first of all, understand this landscape. Don't minimize this issue. It is a big issue, and minimizing it has resulted in a lack of awareness in the larger population as to the severity. So we talk about vulnerable populations. Race is the stark one. Women are vulnerable populations because women are also exposed to stereotypical impressions and biases. If you present as a woman to a cardiologist with symptoms that a Caucasian man presents, identical symptoms, you may have different treatment recommendations. It's documented. This is no speculation. The elderly are exposed to their vulnerable population. Lifestyle, LGBTQ.
Yes.
People that have differential abilities. So it is necessary to develop a strategic approach to ensuring that, first of all, you understand the complexion of your workforce. And you develop strategies that are all encompassing to vulnerable populations so that they can benefit from the resources that are provided, not just by being provided, but by utilizing them. So what I'm seeing, to answer your specific question, is, and the advice we're giving, is that take a step back. There's a lot of reactivity going on now, understandably, around COVID-19. COVID-19, knock on wood, will pass. There will be another one. There will be other things. We need to take a step back and develop strategies that enhance awareness, health literacy, financial literacy, advocacy, that all promote workforce resilience in an equitable manner.
Yeah, it's a tall order, right? And it's a journey, right? It's not a switch, right? Mrs. Jenkins, thank you for that, Dr. Aluko, but I want to come back to you because you touched on something that's really important, and it's behavioral health. This pandemic, we've seen a significant increase in behavioral health needs. Grief, isolation, loneliness, and the healthcare workforce, burnout. We feel that integrated health, including behavioral, is really important. Can you talk a little bit about how you at Howard have addressed this, particularly your healthcare workforce? Because we're relying on you, and they're stressed now, right?
Sure.
So can you talk about that a little?
Sure. I'm going to add to that list. You said there was burnout, there was this. I'm going to add fear to the list. Fear is an interesting nuance. People were afraid. They were afraid to come to work. They were afraid they were going to get their family sick. They were afraid to take care of patients. There were some times when we had to look, you've got to follow this level of CDC guideline, even though, but they were afraid. And that fear it is hard to crack through. And when you start talking about what resources can we offer when it comes to mental health, counseling, wellness opportunities, the Black and Brown community is just as skittish about those types of tools. And I will tell someone in a heartbeat, everybody needs a checkup from the neck up, depending on what happens to in your life, right? If, what are you going through? There have been people who working through this pandemic, then they're having relationship problems, or then they have deaths in their families. It was a huge weight that so many people had to bear. And we were trying to offer, please make sure that you're doing a wellness check on yourself. Please go home and sleep. Please eat well through these times. This is no time to allow yourself to indulge, even though I might have some COVID pounds, but even though, it's quick to get pizza and you don't feel like doing this or doing that, you have to honor your body and your mind and take care of yourself. So we actually just have a brand new wellness. We're not through this. That anxiety and fear and stress levels are still here. They haven't exhaled quite yet. And so it is important for me to still continue to say, we've got to take care of our minds and our souls. I'm a faith-based person. If that's how you believe, I say to them, and I said, then make sure that you are praying a sigh for strength as you face another day. So yes, and there was mistrust in mental health care as well. That's America is not as strong as it could be and should be. And then we defend some things or blame some mental health on mass shootings, or we blame this or we blame that. And we haven't gotten that right either. We must, as organizations and as healthcare providers, press the fact that if you're well up here, you're going to be able to take care of the body better.
Thank you for that reminder to exhale and take a deep breath in, because I'm going to touch a little bit of a sensitive subject.
Sure.
And that is, we are dealing in an environment of systemic racism, and it's an uncomfortable subject for many people. They're allies, they're people who feel uncomfortable talking about race. There are barriers to having conversations. And our HR teams need to go out there and provide benefits for all of their employees. So as we're coming to sort of the end of our hour, if you were going to give specific advice at the end of this panel, you want somebody to write this email or take this action. Let's start with one each, and then we'll go to two each. What would you tell your colleagues or the participants of this conversation, the listeners of this conversation, to think about? What would you want them to do? Because you can't have a conversation if it's not a safe space, right? So can you provide, let's start with, how do you want to create a safe space? And then let's go to specific actions to close gaps in health disparities. Your choice of who starts this one.
I'll go first.
Go ahead, please.
Well, first of all, let me say that I'm actually optimistic. Why do I say that? Because if we remember what happens, not just in America, but across the world, thousands of people were marching in Australia,
yes,
in the UK, over the Black Lives Matter issue, Breonna Taylor, George Floyd, and with the realization of the stark disparities, the world, not just America, stood up and said, this is wrong. Mm-hmm. So there's a realization that there's right and wrong. I'm a firm believer that the majority of Americans understand what's right and what is wrong. Yes, racism does occur. And the gradual realization that the structural determinants of health were not put in place by accident, were deliberately put in place through political and regulatory issues, zoning, redlining, all kind of things, impact ultimately people's health. So with that, minority people need to also understand, and there was a question in the chat that said that having these conversations with Caucasians leads to them shutting down because they feel they're being accused of being racist. So a safe place must, first of all, acknowledge by the potential participants of the place that there is an agreed upon problem seen through different lenses. But this is not about accusing individuals. It is about accusing the appropriate systemic drivers and coming together to figure out how to begin to dismantle them. Not taking people's property one from the other, but promoting a society where the human race can benefit one from the other. And as Mrs. Jenkins said, so doing has been shown to drive societal and human value as well as business value. So it's a long way to go, but I do feel that the soil is now getting fertilized and the world is trying to figure out how do we begin to develop strategies that drive not just health equity, but a better human society.
I like that we are having this kind of challenging questions. There's so many thoughts in my head. It's hard to fine tune that down to a sentence or two, but I would start, Dr. Aluko, it was perfect. But I would start the conversation, and as a safe place is, you do know that everybody wants the same thing. We want to be treated as human beings and valued just like everyone else. Not more, not less, but we want to matter just like everyone else, not more. We don't want to take away anything, like you said. And so we want to have that same value as human beings who want the same things. Black people want a safe roof over their heads. They want strong families. They want to look at their children as future. They want to live good, long lives, just like everybody else. So when you look at that, that should not make white people uncomfortable. They should say, well, that's true, because that's what I want as well. And how do we all get that? You can all agree that pay should be equal for men and women, and that's still not there. Let's just put that out there to the universe. But it is not fair that I have to worry more. My husband and I have 5 children, 2 girls, the second one's a physician, incidentally. And she was the only female and the only Black in her class at WashU. Yeah, she went to WashU. Ooh, right, to WashU, incidentally. Our oldest daughter is the head of a human resources department for Indiana University. But our 3 sons, it is not fair that I have to worry about them more than so many of Caucasian mothers. I think about them in my husband's prayer every morning when we both go to work. Take care of our children wherever they are. We pray that prayer differently, and that's not right. And so as a society, we just want to make sure that each and every person is valuable. Where would you be without the amazing Black and brown and white and Hispanic people who have just made huge marks? But if you don't value their lives, they could end up on the streets dead because of some weird disparity or some predisposition or how they were treated or prejudged. And they could have maybe been the next person to cure cancer, right? So I am just asking, and I start that conversation. You do know all we want is to be a human being just like you. There is so much compassion and empathy and sympathy for pets and animals. I've just noticed this. People care, they care. But they're going to watch some kind of TV video, and they're going to watch some man get shot because he's in the garage working on his car and he has a cell phone in his hand. And they're going to say, well, he shouldn't have resisted. So that just tells me that you don't see that human being the same. We just have to start by saying all of us are valuable in this world, and we have a place in this world, and we've got an important place, even if it's just to be loved and to love. We're important.
I like what you said. I just want to follow up one point here, which Dr. Christina mentioned, social determinants of health. There is a myth and a misnomer that African Americans and Latino Americans are more prone to get disease and die. When I say that, there's this myth, this misnomer that there's a genetic reason.
Yes. Yes.
There is not a genetic reason for most of this. There is a societal reason. So when people say that there are disparities in death from COVID-19, implicit in that is that there's something about the African American biotome makeup that makes them susceptible genetically to disease. The reality is, as Dr. Christina mentioned, 80% of health outcomes have nothing to do with the person's genetic makeup. 20% maybe, but 80% of the outcomes are based on these social determinants of health.
That's right. Where
you're born, the community you're born into, the home community, what type of nurturing do you have, where you work, where you live, where you play. The social environment drives the vulnerability to get disease. It is not the genetic predisposition.
Yes, thank you. So I'm going to pull a mom and ask each of you to limit your next answer to 30 seconds. All right.
Have you met us?
So Board of Trade, grateful to them to give us a platform to talk about health equity. Grateful to Cigna for really making this an integrated part of the work they do. But I'm going to ask each of you in 30 seconds or less, knowing the diversity of businesses in the DMV, the diversity of the community, what is the one thing you want people to do at the end of this panel? Dr. Aluko, I'll start with you.
Everybody on this panel is a business leader. And I would like you not to ingest this as information only. I would like you to take this insight and take it into your leadership circles and begin to have conversations around meaningful strategies, meaningful partnerships that will enable a critical mass of thought leadership to develop corrective action in your small or your large way. But don't ingest this as information only.
Thank you. And Mrs. Jenkins.
And as business leaders and community members, take a look at everyone that you pass by, the people in the store, the people that you are wearing masks nearby, or that you go to restaurants, and understand that there is a value to each human being. And when you start talking about that, then treat them differently, speak to them. I make sure, it's so funny, I make sure that I speak to small, young, white children. Hi, because what is the narrative that their family is presenting? And you can tell, they go, wait, she seemed nice, but she's brown. It is so important for us to make sure that we are building a community narrative, and we have an opportunity to do that. How do we speak to each other? How do we speak on the street? How are we taking care of each other? How are we reaching out to the masses? Each and every one of us can make a difference.
Okay. Thank you. Thank you so much. So thank you to the Board of Trade and to Cigna, Mrs. Jenkins, Howard University Hospital CEO. Thank you so much for sharing your insights. Dr. Aluko, Chief Medical Officer, EY Americas. Thank you. Really, it takes a village, and I appreciate all of the input that you've given to this conversation.